Hello, my name is Clifford Moore, and I chose to interview a former colleague and now friend of mine who is a nurse practitioner in the cardiothoracic ICU at University of Washington Medical Center. Her name is Rebecca Robinson, and she's a great influence to me, has always been so thoughtful and helpful, not only in guiding me as a bedside RN, but I predict in the future as a nurse practitioner. So here she is.
My name is Rebecca Robinson. I'm a cardiothoracic ICU nurse practitioner at University of Washington Medical Center. And I have been an NP for about 2 years. Prior to that, I was working as an RN for about 20 years and went back to school and now work as an NP at UW.
Thank you. And thank you for taking the time to do this interview.
You're welcome.
So I'll start off with one of the questions that I found important. What job-seeking strategies would you advise new graduates to use in today's market?
One of the things that was recommended to me while I was in school was to make sure that you emphasize clinical practice that you've had while you're in school, as well as clinical practice that you have had either as a nurse before or any other clinicals. Because even as a new grad, you don't come without experience if you've done clinicals in a certain area. So it's really beneficial to include that, as well as what your duties and responsibilities were within those clinicals and how many hours you put in. The employer that I have now did look at that and considered that when I was evaluated for the compensation package. And ultimately, I ended up getting a better compensation than some of the other new hires at the same time, strictly because I had had more clinical experience in the area that they were interested in.
Awesome. That's good to hear. That's promising.
Mm-hmm.
Did y'all use something called Typhon to log your clinical hours? Yes. And did your employer, did you utilize that at all?
Look at that.
Okay.
No, this was all stuff that it was entered in my CV.
Okay, nice. And then what kind of practice privileges do you have in your practice right now? Like admitting, treating, consulting, discharging? Where do you fall, I think, in that realm? And what are your capabilities independently?
Yeah. So within the cardiothoracic intensive care unit, we do strictly post-surgical management of cardiothoracic patients. So the only admitting providers are the attending within cardiac and thoracic, and actually we do have vascular patients there as well. So as nurse practitioners, we do not admit to our unit. We are considered a primary service, so it is a service that's provided by intensivists. But the admitting provider is not the intensivists themselves, so we are in a consulting partnership with the surgery team.
Nice. And I feel like that leads into the question of what kind of collaborative arrangement do you have with your physician groups?
Yeah, so because it's an academic medical center, we work with residents, and the attending is there to supervise the residents. Specifically, they are not required to supervise us, and we practice independently, but because there is so much teaching going into helping with the training of the residents, we are actually, part of our job title is a teaching associate, and we round as a team collaboratively with the residents and the attending, and in that fashion do have a lot of team collaboration with the attending, but they are not in a supervisory role of the nurse practitioners on our team.
Oh, great. And then kind of changing the subject a little bit of it is, what do you know now that you wish you had known earlier in your career? And I feel like it's a little early maybe to ask that question, but in general, is there anything that jumps out to you about that?
I think one of the biggest things for me working in academic medical center care is that we as nurse practitioners are expected to guide and teach the residents, as I mentioned previously, and that was something for which I had essentially no training and had never worked with physicians where I was expected to help them deliver their care and supervise their care plan. And so from that aspect, I wish I would have known that, because I probably would have sought out some mentorship prior to this job.
Okay. I mean, that sounds fair. I can imagine the stress of that, trying to mentor somebody else, and you're like, I'm trying to get this myself.
Yeah, exactly.
And then back kind of to the educational aspect of being a nurse or becoming a nurse practitioner, what were some of the most valuable aspects you found in your graduate educational program versus maybe some that you didn't find as valuable now in practice?
Yeah. So everything that I learned in my nurse practitioner program that was hands-on, so all of the skills for all of the invasive managements that we do, the bronchs, the central lines, the A lines, all of those I thought were very good. And also we had a practice, sort of a professional development class that in which we were required to create a 3-minute elevator speech about our identity as a nurse practitioner, which I thought at the time was a very corny assignment. But as it turns out, I have used that same elevator speech time and time again when people don't know how to look at nurse practitioners and don't know the language around it, and to help guide people about where we fit into the healthcare system at large and where we can really come to the table and serve as excellent members and stakeholders within healthcare.
I think that's great because I think all of us as students definitely suffer with understanding the importance of like that 3-minute elevator speech until we need to explain to people
Right.
what it is we're doing and how we fit in. And so I think that's awesome.
Yeah, and it's good to have rehearsed that.
So yeah, exactly.
Like, hubba-da, I don't know.
I don't know. We're just here to do this.
Right.
Yeah, no, I think that's great. Thank you. And then another question I wanted to ask is so it kind of ties into when you were talking about some of the more invasive procedures, and we've talked about this before, is how do you have a system for reimbursement? Like I personally in courses haven't gotten to that part yet of like how that really works. And I think it depends on your practice. Like yours is in a hospital setting. So I think that differs from maybe a clinic setting where maybe you're doing a little bit more of your own billing. How does it work for you though in your practice?
So at the University of Washington Medical Center, that we have billers and coders that review all of the documentation. And so we are not independently billing for each hour that we provide patient care. And they are able to glean from our notes what is appropriate to code and how that gets billed to the patient's insurance. Separate procedures, as you mentioned, are billed through our division, so the Division of Cardiothoracic Surgery, and that is not reimbursement that we get independently, but that does come back to our division, and overall it helps contribute to the financial success of our division, and that pays for our salary. So there's no direct benefit to us, but it does, come through our division.
Benefits the program and ultimately benefits everybody's paycheck, I think.
Precisely.
And this one is kind of, I think we touched on it a little bit, and I wanted to see if you had any more insight for me, is like, what were your experiences with I think I would like to know what your experiences in getting mentored. How did you find the right person, or do you think you had everybody that was the right fit, or were some maybe not? And how did you kind of suss that out, I think?
After graduation,
or even in clinicals, actually, like when you started doing clinical hours and things like that, how did you determine who was going to be a good fit for your education?
I think that's kind of hard because especially in clinicals, you don't really get to pick who your mentor is going to be and how you're going to get taught. There's some very excellent mentors out there who are great teachers, and then there are some who expect you to just shadow them and learn whatever happens to fall by tidbits your way. And there's no way to know that before you commit to a clinical assignment. But then as far as afterwards, I would say it was probably very similar to any onboarding process as a new RN anywhere. There was a 3-month mandatory orientation, and during that time we are given 2 primary preceptors, but then you also precept with other people as the schedule requires. And again, I think we have, as a team, developed more of a directed orientation where we allow more focus to be given to different experiences throughout the clinical rather than just incidental education, which is not necessarily guided so well, and also allows for a lot of knowledge gaps. So we as a team have worked on that specifically.
Good. I mean, I feel like, yeah, I can only imagine going out into a new field, even though we've worked as nurses before, but at a very different scope.
Mm-hmm.
Kind of like, oh, what does that mean? Oh, am I
Yeah.
going to learn about that now, or we'll wait till later? Or so I think that's great that
Yeah.
y'all are working on it. Anything else that you think that, because my classmates will be seeing this as well, that you think we would benefit from knowing maybe ahead of time, or any advice to us?
Yeah, I think one of the things that was told to me still rings true when I was in school is the difference that you have in how you work with your previous peers. So you were an RN and you were working with all RNs, and now you are not their peer anymore. And to a certain extent, you need to have them buy in to the fact that you now have a different level of respect for them, and they will have likely a different level of respect for you. And so that will change just by its nature. The camaraderie that you may have had with your peers before, that is a switch. And you're not, you're not quite a doctor, but you're also not an RN anymore. And so I was told in school just to keep in mind to kind of tread lightly through those waters for the first year or so until you have the absolute buy-in and support of your peers, because these RNs are going to test you, and they may question a lot of the decisions that you make, and that is not something personal. It's just how growing happens. So the profession does need nurse practitioners, and I think we have a great collaboration with the RNs, but there's sometimes some dynamic shift there that happens, and just be prepared for that.
Great. Thank you so much for sharing everything.